rush at once.
Thank you very much. Catherine Hayes from Public Health and Primary Care, Trinity College, Dublin. Just a question to the last speaker. I was just interested in terms of the wine drinking. Were there any differences for red and white wine, or is it for both?
This is basically related to the prevention of ischemic heart disease. It's basically alcohol. The beverage type does not matter. So there have been a lot of meta-analytical studies that have looked at the reduced risk of heart disease by beverage type. And the reductions in risk are exactly the same for just people who only drink beer as people who only drink wine or who only drink red wine. There have been some arguments that red wine has other kind of chemicals in it that might also prevent heart disease, but in terms of the kind of studied effect, that's irrelevant. It's alcohol that's the important thing.
Yes, thank you.
First of all, I want to thank very much the organisers for this conference. I think it's brilliant. And I'm very pleased to note that the Global Monitoring Framework managed to get the alcohol into the risk and to the indicators, because that was, I know, a struggle. I also had a comment for the when you are doing the new codes on the drinking guidelines, because I just wanted to mention that the member states are going to do a joint action now for the next 3 years. And one of the issues there is to discuss drinking guidelines. So it would be good to have that coordination between the EU member states and the codes.
Okay. Yes, please, Peter, comment. Yes.
Thanks, Marion. I think that's a really important point. I think that if any European countries are kind of revisiting their guidelines on drinking, one of the best models that they should look at and follow is the Australian guidelines, because about 3 years ago, the Australian government commissioned a kind of review of what advice to give to people about drinking. And this was done in the most kind of thorough and evidence-based way, and basically came up with very good evidence of what is the risk of death from chronic diseases or risk of death from acute diseases in relation to your average alcohol consumption or how often you drank. And basically just showed that risk goes upwards, so that when you're developing guidelines, you have to reframe them in the sense that if you drink at this level, this is what the risk is. So it's just to, I think, note that for countries that are doing it. Look first at the Australian guidelines.
Is this working? This is working. If I could reinforce this with the Global Monitoring Framework discussion, as maybe a few of you know, if you've been involved in the discussions, it was a great debate as to whether to have harmful episodes of harmful drinking or alcohol per capita consumption. The debate was not quite resolved. It ended up being both there, as well as looking at drinking in young people. The end result is quite a rich range of indicators that we should all now be looking to monitor going forward, and it will give us an even richer evidence base. But staying also with this subject, in the European region, ever since the work started on alcohol, Peter Anderson's time in WHO, among others, the slogan, the campaign has been less is better. And in terms of the type of language that we should use or consider for both European as well as national communications, going down the slope of those response that we have been seeing is an important message to make. And we should not be implying that there's a threshold below which there's a safety limit, which is implied sometimes by the language on harmful use of alcohol or harmful alcohol use, that one has the global consensus takes us to that language, but in terms of communicating with the community, it needs to be very clear that there is a dose response and less is better.
Hilton Sunset, European Institute of Women's Health. Now, thank you very much. I'm afraid I came in rather late, so I just have a comment and a question for Professor Anderson. Women, as we all know, are now, or young girls, I should start, are now catching up with boys in alcohol consumption. Binge drinking is on the increase. And so it's really an issue that we are very concerned about, as it's a major risk factor for women's health, not only for their own health, but passing it on to the next generation for the unborn child when they're pregnant. So my question to you is, Professor Anderson, you mentioned the safest level, if I got it right, is 2 drinks a year. Is it the same for women, or would you say even lower? Because we know that women, women are more vulnerable to alcohol. They metabolize it differently and all of that. So should we still make the distinctions there? And what do we advise pregnant women or women who are trying to become pregnant? Thank you.
Thank you. When I mentioned the alcohol-related cancer exposure, that is not a safe level. I mean, that is just what is a level that reduces public health risk to very low levels. If you look at the dose-response relationships comparing men and women for different conditions, you find 2 interesting things. If you look at the chronic diseases, things like cancers, cardiovascular disease and so on, then it is true that at any given level of consumption, the risks are steeper or greater for women than for men. Whereas if you look at accidents and injuries, you see the opposite picture, that in fact the risks at any given level of consumption are greater for men than for women, just because men tend to behave more stupidly when they get drunk. And in fact, if you added if you put all of those risks together, the curves are pretty well the same for men and women. So you need to differentiate out whether you're going to talk about chronic diseases where there is greater risk for women than men, or the acute diseases where there's greater risk for men than for women. I mean, to me, the message exactly is the message of less is better. It's very problematic when you start trying to give levels, because you open yourself up to all sorts of comments and criticisms and difficulties, because the risk curves are for most conditions basically start at 0 and just go upwards. So there is no level of consumption that is risk-free for most conditions. Therefore, the message less is better, encouraging all of us to drink less frequently, and to drink less on any occasion. Those are the messages that have health benefit. For the pregnancy issue, the story I think is still out. Are very low levels risky or not? I don't know, but it seems to me that kind of the simplest message and the safest message would be just if you're a healthcare provider, would be just to say don't drink when you're pregnant.
Cora.
Holding of the Dutch Cancer Society. I have a question for Dr. Schuz. I was very pleased to hear that you have added a working group of communications to your European Code procedure. Do you happen to know whether they will involve the lay public in understanding the new version? Because we all could do our best to formulate it in a very clear and comprehensive way, but we could learn a lot of the feedback from the users of the European Code.
That's a very important comment, and of course this is an essential part also in evaluating the code. So we start with small focus groups already, and this has to be expanded, even when it might be a bit difficult really to put it on a very large platform that is maybe needed, that it captures all segments in a population. And of course another challenge then in the second step will be that even if you have an English version of the code ready that is optimized also when it comes to the language, this has to be captured and also in all the European language. And we already see in our discussions in the working groups with all our Swedish English, German English or French English interpretations that sometimes the English expression is differently interpreted in the different languages. So we also have to secure the process that the precision that we try to get into the English version is still secured in the national translations.
Yes, my name is Florence Bertaletti-Camp from the Smoke Free Partnership, and thank you very much, Peter, for your wonderful presentation. My question is to all of you, in fact, because if we consider the slogan "less is better," perhaps we're missing the elephant in the bottle, in a sense that alcohol is a disinhibitor. It's a psychoactive drug, and if we were going to put labels on bottles, wouldn't it be better, instead of saying alcohol causes cancer, to actually tell the truth and say this product contains ethanol? Because that would definitely inform the public about what is in the bottle. Or this product contains a psychoactive drug. What would be your reaction about this?
Not from evidence, but from learning in the area of tobacco. What clearly works in the area of tobacco, as we all know, is very clear graphic warnings that illustrate the consequences. It would need to go through a cycle of testing, I am sure, to find what would work in the area of alcohol. We clearly know that language such as drink responsibly is already language that shifts the blame onto the victim and even contains the encouragement to drink. So we know what doesn't work. We know from tobacco what has been most effective, and then have to work at what the reality in any country would be in terms of what would be the appropriate language. My instinct would be that just referring to the chemical might distance it from the actual decision of the moment, and that the person might not internalize the danger that they are doing simply by hearing the chemical name, and that the suggestion would be to make the impacts as graphic and as immediate to that decision of purchase or consumption as possible.
Now, Emma.
Hi, Emma Woodford from European Cancer Leagues. There's a lot of discussion at the EU level now about the alcohol strategy and whether Europe needs one or not, or what would be in the next strategy. For all of the panellists, which one chooses to answer, and what would be your recommendation for the Commission to put into the new alcohol strategy?
There was a meeting in the Parliament, was it, Marion, a week or so ago, where a number of parliamentary MEPs and a number of other people kind of met together yet again to say that the European Commission should develop a new strategy. I mean, I think that the point being is that there needs to be, I mean, in many people's minds, the present strategy has finished, although the Commission says not. But in many people's minds, the present strategy has finished. And I think it would give a very good signal to public health at the European level and at the member state level to relaunch that strategy and to make a new strategy. We have in the WHO action plans the model content of that strategy. There's 10 action points in the global strategy and in the European strategy. And they would be a very good frame for the European Commission also to adopt, so thus being more aligned to the WHO process and more aligned to what public health evidence says should be in such a strategy. So I think, the more all of us make this argument and get our countries ministries of health to make this argument to the level of the European Commission, the better.
Now there's a gentleman down here who has a microphone. Yeah, I'll go to you next.
I think some of the problem with the alcohol messages is the drink responsibly. Somebody mentioned that earlier. I mean, that's funded by the drinks industry. So and one of the drink aware messages is that you should drink at your own pace, or the best pace to drink at is your own. But if you look at the advertisements, right, most of the people in the ad of the drink aware ad are standing. And it's well known that if you're standing in a pub, you're going to consume more because you've no place, you've no table to put your drink down. So there's a mixed message coming through there. So just to make people aware of that. Thank you.
Now there's a gentleman down at the end, and I know there's a lady here.
Is this working? Hi, Greg Conlon, Health Promotion Officer in St. Vincent's Hospital. Just echoing a little bit of what the last commentator said, and I actually have a question for Professor Anderson. I think as health professionals, we all need to advocate in terms of our own alcohol consumption and setting examples for the general public. And I was wondering, Professor Anderson, if you could comment on the prevalence of alcohol abuse within the medical profession, in particularly in relation to GPs, as there seems to be some worrying statistics in terms of abuse, particularly in the UK. And if you would have any statistics in relation to that'd be very useful. Thank you. I'm trained as a GP. I used to work as a GP in Oxford many years ago, and in fact had a senior partner who had alcohol problems. At that time, an alcoholic was defined as someone who drank more than their doctor. And in fact, at that, if you look back sort of 30, 40, 50 years, it is true that doctors in the UK had higher cirrhosis death rates than the general population and than people in their own socioeconomic grouping. But in the UK, that's actually come down, and now UK doctors have one of the lowest cirrhosis death rates of any occupational group, also lower than people in their own socioeconomic status. So maybe the doctors themselves have kind of got the message. I agree with you that we should all set our own examples. I mean, alcohol might be more difficult because most of us, or many of us, or a lot of us, drink and like to drink. And maybe we should just accept and say, it's fine, we do like to drink, but let's all try and help each other drink less, or whatever the message should be.
Back, is that okay? Yeah.
Thank you. Marion Rackett from the HSE. I was just in relation to what the second last speaker mentioned in terms of the drink industry messages around alcohol. I'm wondering, in the new global prevention strategy, in terms of managing those messages, because if for every single marketing ad, either on television or radio, we hear enjoy alcohol, it's totally counterproductive to the other key message which we're all trying to get across. So just wondering what other governments may be doing, or what the global action may be doing on that. And just the very last one is in relation to Dr. Allen, in terms of synergies and, that risk. I'm thinking of, I work in the addiction area, and the premature death and chronic illness from alcohol use disorders. And I'm wondering if there is any new evidence on that link, or is it just in terms of dailies or mortalities? But is there any specific research looking at the health implications of alcohol use disorders? Thank you. And cancer.
I'm not aware. Is this working? I'm not aware of very recent evidence, although I'm sure you'll be aware of anything relevant.
I didn't quite understand your question about alcohol use disorders.
Meaning alcohol dependence syndrome and premature death.
Oh, okay.
And cancers and chronic illnesses. And that whole mix of synergies that Dr. Allen was talking about.
And just to mention that when not directly to your question, but when the panel the expert panel were doing their deliberations around what to do about alcohol, there was a tremendous amount of kerfuffling and discussion and arguing, precisely because of this issue about the fact that the evidence shows that there's no safe dose at all. And so some of the panel wanted to say don't drink alcohol at all, but they also wanted to kind of live in the real world, if you like, and reflect people's real behaviours. And if you say don't drink alcohol, it's very difficult to sort of get that implemented across the board. And that's why they came up with the recommendation of the 1 drink for women and 2 for men. But that's also something that will be looked at when the recommendations are revised in the light of the latest evidence.
About a year ago, Jürgen Rehm and colleagues produced a very good report for the European Union looking at the contribution of harm from people who were heavy drinkers or people who had alcohol use disorders or who were dependent on alcohol, and showed, in fact, that the vast majority, contrary to what many of us thought, that the vast majority of harm in the European Union, health harm anyway, comes from that group of people who are heavy drinkers or who are people who are dependent on alcohol. So that group also needs to be a target group of all of our interventions. And the problem for that group is that there's a huge treatment gap between the number of people who could benefit from help or treatment and the number of people who actually access it. So again, at a country level and at a European Union level, I think anything that can be done to close that treatment gap, again, should bring great health benefit.
If I can add to the part of your question which connected to the strategy and policy implications, both the global strategy and the European have very clear recommendations in terms of the price, marketing and packaging of alcohol to simplify the recommendations among the 10. I am driven by the questions that I am hearing, which are all about alcohol, to say how much in its infancy the control of alcohol is compared to the tobacco story. And I would like to bring the attention also of ourselves in the coming months to what I would call the policy emergency that we are facing. If we, for all the aspirations that we have, for example, for controlling the marketing of alcohol or reducing the price or increasing the price in order to reduce consumption, we are going to be facing even greater opposition than we have in the area of tobacco. And if with such clear momentum behind us, one can't get a tobacco products directive through the heckling and the amendments and the protests and the lobbying that is happening against it, I can't imagine how we could even get weak measures through on alcohol. This is another area where synergy also in messaging must be important. If we, in the area of cancer, ignore the dose response curves and talk about limits rather than reducing quantities, then we might as well toss in the towel in relation to the cardiovascular impacts of alcohol. And we really need to be aware of these two elements, the synergy between our work on tobacco and the emergency of the Tobacco Products Directive, then moving on to alcohol, and within alcohol to realize that cancer is part of the overall NCD problem, and that less is better is the sort of messaging that we should be going forward.
We have one question here behind you, Florence. That lady has had the mic. Yeah.
My name is Lisa Corbett from Health Promotion Services in HSE West. My question is aimed really at Dr. Allen. It's changing the focus to food. One thing that's been mentioned is about the labelling of alcohol and saying about the levels of ethanol and things on it. I think as well, if there were labels giving any kind of guidelines as to what's in it, I think the calories would be something as well that may be something that would make some people reduce their intake of alcohol as well. One of the initiatives that we're involved in Galway is we run supermarket nutrition tours where we take groups of people around the supermarket and show them how to read the nutrition labels on the food so that they can make an educated choice. You mentioned that, Dr. Allen, and in your nourishing framework that you're working on. Would you see the traffic light system as being one of the best ways of labelling foods, or what method would you see as the best? Because I think at the moment in Ireland we don't have the traffic light system, so it's very hard for people to remember the relevant numbers and to know what levels are high and low. And obviously, you know, you come up with issues in terms of working with the alcohol industry. Working with the food industry is obviously also very difficult in them allowing you maybe to put a lot of the relevant nutritional information on the labelling, because the advertising is so good. I suppose they have so much money to put into that. But what would be your opinion on labelling on foods?
Well, WCF International supports in general the traffic light system, because the evidence shows that that's very effective. People understand it and people prefer that kind of labelling system to having a list of ingredients. I know that there are lots of different kinds of labelling mechanisms, and in fact recently I think Consumers International did a quiz that people had to go through that had the same products, some that had just a list of labels and some that had the traffic lights, and when people went through, not surprisingly, they had a much better understanding of what the constituents were from the traffic light system. And I think in the UK now, all the major supermarkets have agreed voluntarily to go to a traffic light system. So I think the evidence shows that people prefer that kind of interpretive label because it's just easier to understand. It's much easier than having to look at a list of ingredients and try and work out, what's what. Whereas it's much more visual if you've got the traffic light system or a similar labelling system.
You could go one step further, couldn't you, and have intelligent supermarket trolleys that actually kind of measured your calories or your fat or whatever as you went on, and could even say, well, why don't you swap this product for that product? Because that, there's the technology's there, and make it shopping much easier.
On that, we'll have to draw a close to our panel discussion. I know there's a couple of people who still have questions. I'm sorry about that, but I think our speakers are remaining with us for the next short while at least. So please, maybe you could address your question to them personally over the lunch break.